Next, Dr. John Hunter will speak on acquisition of competence, proficiency, and expertise.
Mike, thank you very much, and it's a great pleasure to be able to talk to this group. I think much of what I'm going to say has already been said, and that would give me a great deal of heartburn, if you will, except that I learned from my president recently that the art of communication is saying things 9 times, and so this will be number 2 of 9 for David's talk in many respects. Dr. Mavi and I have been working closely together for a good part of 7 years at the Board of Surgery and through the GI Advisory Council, so I think we've arrived at many of the same conclusions. I'm going to come to it from a slightly different perspective, however. I have no disclosures relevant to this presentation because no one pays for education anymore. It's kind of ironic that most medical students are $200,000 in debt, however, despite that. So the objectives, I'm going to really talk about the pathway from novice to expertise and talk about where competence lies in that pathway. And then I'm going to briefly talk about something that LD, I think, laid out for you very nicely, the Milestones project, that the next accreditation system, as Dr. Naska has published in the New England Journal of Medicine. So the novice is someone who is inexperienced, a beginner. Someone's competent is one who is properly or sufficiently qualified to do something successfully. And an expert is a person who possesses a comprehensive and authoritative knowledge or skill in a particular area. We all kind of know that, but I think it's helpful to put definitions to this at the outset because these are the touchstones of the rest of this talk. Most of you, I think, are familiar with the Birch classifications. I'm calling it the Maslow, but actually it was Noel Birch who described this in the 70s. 4 stages. The first is unconscious incompetence, and that is you don't know what you don't know. The second is conscious incompetence, which is the beginner. You don't know what you know what you don't know. You want to learn it. That's sort of my golf game. Then conscious competence is something that you become successful with deliberate performance, and that's where I hope my golf game gets to, but it's not getting there. And then the expertise really is when performance comes without thought, and again, that's in this room as doing surgery, that's what we all aspire to if we're not already there. Now, probably the better classification, which is used by the ACGME, is used by most people who study this field, was published by Dreyfus and Dreyfus brothers, a philosopher and an engineer, and this was selected and presented to the National Academy of Science in 1980. You'll find it on Google with a Smith-Corona type PDF file, as you can see the title here. And it's a 5-stage model. And the 5-stage model starts with the novice, the beginner, the competent in the middle, the proficient, which no one's really talked about today, and I'm going to spend a little time talking about proficiency, and then expertise. And I'm going to spend just a few minutes on this slide because it's a complicated matrix. But if you look at the characteristics, maybe we'll just start there. The novice has little judgments, rules dominated. The beginner gives all attributes to a situation equal weight. Competency, you're beginning to deal with crowdedness, and you're looking for sort of standardized performance. Again, this really speaks to what the ACGME is trying to do with competence. Proficiency is when you begin to see how what you're dealing with deviates from normal patterns. And then expertise is really sort of a gestalt, a holistic or intuitive approach in which you often, all your rules are put aside because, as David said, you just know when someone looks sick. And then, again, I'm not going to go through all of these columns. I'll just kind of take you to the last column to help sort of take you to some of the differences between the expert and those that are even proficient is rational decision-making versus intuitive decision-making. Again, when you kind of cast rules-based behavior aside. So how long does it take to achieve expertise? Well, David alluded to the magic 10,000 hours, which you will find in Outliers and many other publications on expertise. The other piece of this is 10 years, and this is through studies of chess players and concert violinists. But the domain expertise in surgery is a bit more complex than chess players or concert violinists, because we have to have two really very distinct skill sets. One is psychomotor skills, in which deliberate practice and experience is important, and then analytic skills, a knowledge base, pattern recognition, judgment, some of those other attributes. So it isn't surprising that it may take a little longer. Now, again, this is sort of looking at the categories. The novice is that with minimal or textbook knowledge without connecting to practice. Again, you can read across here pretty easily. So I asked Mike, who do you think that describes in our residency training paradigm? You look at those. So the novice is basically someone I think would describe the intern, needs supervision to perform tasks. The beginner just goes a little bit deeper. There's a beginning to get a working knowledge of key aspects of practice. You're able to do straightforward tasks. Again, you can think of a central line perhaps as something that can be done on their own. Supervision is still needed for the overall task and appreciates the complex situation, and then sees actions as a series of steps. Again, I would say that's probably our junior resident. I think you can see that in the junior residents. They're learning how to do things step by step by step, and they can get there. Now, competence, again, is what we aspire to when we finish a person from our program. And again, if you look at this, it probably makes pretty good, it has pretty good face validity. There's a good working and background knowledge of areas of practice. They're fit for the purpose, though they may lack refinement. They're able to achieve most tasks using their own judgment. They cope with complex situations through deliberate analysis and planning, and they see action at least partly in terms of longer-term goals. Okay, so there's your chief resident. Okay, so that's, now we finish people kind of halfway through the curve. So residency programs establish competence. Now, in general surgery residency, if you add up all the hours in a 5-year clinical program, it's a great deal longer than 10,000 hours. It's 15,000 to 19,000. It's over 5 clinical years, however. Establish competence. It doesn't get you to proficiency or expertise. And why not? And I think the why not is that it's really too broad to create the focus necessary. And again, Dr. Mavi alluded to this when he said you could take someone and train them to do hips in 3 years, but that's all they're doing. We're training people to do a whole lot more than that. Too many domains of knowledge and skill, too few years. Again, it's only 5 years, not 10 years of training. And there are intrinsic inefficiencies to our learning process, a lot of downtime in a residency. So moving to the last 2 levels here, proficiency involves a depth of understanding of the discipline, areas of practice, fully acceptable standard achieved routinely, is able to take responsibility for the work. So this is kind of the autonomous step, deals with complex situation holistically, and sees the overall picture. Okay, so that to me is the fellow, the instructor, the person, the junior faculty member. That's the proficient. So how do you get from competence to proficiency? You need additional focus learning if you're learning a fellowship, a transplant program, or a vascular surgery. You need additional autonomy. That word keeps coming up. You need additional experience. You need additional responsibility. And you need to learn efficiency, which all of these things are kind of learned during those first few years of practice or fellowship. So do you have to do a fellowship to gain proficiency? And I would argue that you don't really. You can gain it in a broad-based practice of general surgery, but if you do that, you're going to need mentorship. You can't do it just kind of by going to Reedsport, Oregon on the coast and practicing on your own. You need someone looking over your shoulder, someone to help you. And you need what I call structured autonomy. The structure piece is the structure provided by your mentor. So lastly, to getting to the expert is again, authoritative knowledge of discipline. The excellence looks like it's done with relative ease. You look at Tiger Woods swing a golf club and it just looks easy. Able to take responsibility for going beyond existing standards, the holistic grasp of complex situation, and kind of sees the overall picture. So that's the experienced surgeon. So, you know, the focused practice is really what it takes to get to expertise. And it probably does require 10 years. The 5 to 8 years of training that we provide, and probably 3 to 5 years in a mentored setting. And that depends a little bit on whether you're a pediatric heart surgeon or you know, a general surgeon or a complex GI surgeon or whatever. So there's some differences based on the specialty you choose. It is possible to get to that expert status without tight mentoring, but again, difficult. So there's not a whole lot of literature on this field. You haven't seen much quoted yet, but there is one study that asks the question, is there a naturally gifted surgeon? Turns out that manual dexterity does not predict rapid acquisition of skills. So the old dental school trick of carving chalk doesn't do much for you. The visual spatial ability best predicts rapid skills acquisition. Planning and preoperative visualization of the task, so thinking about what you're going to do before you do it, is probably much more important than psychomotor skills. So that integrative step is a good predictor. And as we used to like to say in English class, a willing suspension of disbelief is important in the simulation center to allow the task transfer from the simulated environment to the operative task. So I'm going to talk just briefly about the role of experience in surgical expertise. It's often disparaged as a crutch for those who don't know the evidence, but it is vital for the creation of expertise. You can't get expertise without experience. It allows that transition from the analytic to the holistic I talked about earlier. And it's not just seeing many patients. It's assembling the evidence, it's solving the puzzle, it's recognizing the similarities and differences in the puzzle pieces. That's how you gain expertise. When you look for the, with using experience in the acquisition of surgical expertise, the solution really becomes automatic. And the difference between the educator and the expert is the educator, like Sachdeeva, can explain exactly the path to the solution, where the expert can't always articulate the solution. You can just do it. And then, of course, good judgment is the hallmark of the expert, and I think we all know how you get good judgment. It comes from experience, right? So that, too, fits in. So I've got about 2.5 minutes left, and I think LD has covered a lot of the milestones, and you saw the talk was entitled Milestones. But I do want to touch on this because I think it is very important and ties in very closely with what I've just talked about. Specialty boards have historically only tested medical knowledge with an in-training examination. Most emphasis has been placed on the board examinations, and that occurs at the completion of formal training, or in the case of some disciplines, like plastic surgery, orthopedic surgery, several years into practice. The ACGME has charged the specialty boards and the RRC to develop milestones, which are measurable performance standards achieved and documented through the course of a residency program. And it's really a move from the structure and processes of a residency to the outcomes of residency. And this is the article that Dr. Britt alluded to, published 2 weeks ago in the New England Journal of Medicine, based on 6 core competencies. And as you heard, 7 disciplines are moving into this Milestones project on July 2013, and everyone else moves in July of 2014. Now, Dick Bell has kind of alluded to one of the problems of this, which is that if you want to train competence in the 6 competencies, individuals may not proceed in a linear fashion towards the goal of competence in all 6 domains at a linear rate. And so just an example of this might be that professionalism is gained very early to the rate of competence, and other skills may take longer and follow different paths. So what are some of the proposals? Well, the American Board of Surgery, faced with this, created a task force which reported some thoughts on what the milestones might be. The first that was suggested was a 70% correct on the ABSITE exam in all years. And again, LD has pointed out some of the difficulties with this. PGY1, completion of ACLS in the first 6 months. the fundamentals of laparoscopic surgery, a SAGES product at the end of the first year. Passing your Part 3 USMLE in year 2, ATLS by 18 months. Again, these are just proposals, but the thing that the Board of Surgery has done, I see Joe Beiske in the audience from the board as well, and I'd love to have her comments, is pick things that you can measure. A lot of what we saw in the NASCA article has things you can't really measure very well, and I think the Board of Surgery will want to do that. Then the FLS, the cognitive portions in PGY3, and then in PGY 4 and 5, actually getting into the performance of procedures, not just the actually technical performance, but the whole procedure put together. And so I'm going to finish by saying the surgical residency established competence in surgery. Fellowship or structured autonomy in practice creates proficiency. It gets you to that next step, which is important. And expertise requires a single-minded dedication and deliberate practice, whether it's a woodwind or a Whipple. The ACGME will require demonstration of competency acquisition along the road, otherwise known as milestones. And so a last thought really echoes something that Dr. Mavi said, brought up. What do our patients want? Well, you know, if they're going to have a very simple procedure, such as the lipoma removal, their competence is probably okay. But that's not really why we're training general surgeons. We don't want people just to remove lipomas. We need people to do a whole lot more than that, especially in the ERs in the middle of the night. So complex, modestly complex procedures, such as an inguinal hernia, you ask around, they want someone who's proficient at it, at least. And then when you really get into the areas of complex procedures, that's when expertise is required. And so we have to have people who can do all of these three, but particularly in the last two areas. And I don't think we can do it with our current programs. Thank you very much.